morning, Dr. Anand Patel.
Hi, how are you?
Hi, how are you?
Doing well, doing well.
of Mumbai Hematology Group. Our guest speaker for the day, Professor Dr. Anand Patel from Chicago, USA. All of our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing the Saturday evening, morning, or afternoon from whichever part of the world you're logged in.
ઓકે હા બધું આવી ગયું 3-4 આવી ગયા બધા ડેસ્કટોપ ઓડિયોનો સાઉન્ડ ઉપર નીચે કંઈ નહીં થતું હા એ ઉપર નીચે થાય છે નહીં જતો એટલે હું પેલી વેબસાઇટ પર ચેક કરી લઉં
I am part of the leukemia and myeloid malignancy program at the University of Chicago. And really today what I'm looking to highlight is non-transplant treatment of MPNs in 2024, so in the current day. So I'll be talking about both standard strategies and some novel therapeutics that may ultimately influence how we practice moving forward. These are my disclosures. And really the objectives of today's talk are twofold. The first being a review of our current diagnostic and treatment approaches for polycythemia vera, essential thrombocythemia, and myelofibrosis, while incorporating data from novel therapeutic strategies. And then the second point I would like to focus on is how we consider management of MPNs as they progress to the accelerated requirement phase.
Doctor, can you please
So yeah, the second half of the talk will be focused on management strategies for accelerated and blast phase MPNs. So briefly reviewing the traditional Philadelphia chromosome positive or negative MPNs, you have your three disease phenotypes. You have polycythemia vera, which is typified by an elevated hemoglobin hematocrit, and virtually all patients will have a mutation in JAK2, the majority of which will have a mutation in the JAK2 V617F. You have essential thrombocythemia or TP, which is typified by an elevated platelet count. A majority of patients carrying a JAK2 mutation, with another 30% of patients carrying a CALR or a MPL mutation, and about 10% of patients having what we call triple negative disease, meaning they do not carry any of the three canonical mutations. And then we have primary myelofibrosis with PMF, and the blood count abnormalities in PMF can actually be quite variable depending on what stage of someone's disease they are diagnosed in. If they're in the cellular phase, their blood counts may be high, they may have leukocytosis or thrombocytosis. As they reach the fibrotic or burnt out stage of disease, they will become progressively cytopenic, with the bone marrow showing increasing fibrosis and atypical megakaryocytes. The molecular profile of PMF is much like ET in that most patients have a JAK2 mutation, about 30 to 35% of patients will have a CALR or MPL mutation, and about 5 to 10% of patients will have triple negative disease. So what do we worry about in patients with MPNs? When thinking about the route of progression in these diseases, in my mind I really think of two major complications. Is there risk of progression to a fibrotic stage of disease or myelofibrosis? Or is there a risk of progression to the leukemic transformation of disease, what we refer to as accelerated phase or blast phase? Accelerated phase is typically the terminology we use when the blast is 19%. Blast phase is the terminology we use once the blast percentage is over 20, otherwise also known as post-MPN AML. So let's first focus on polycythemia vera. Really the goal for polycythemia vera is currently to manage symptoms, reduce risk of thrombosis or hemorrhage, and try to prevent progression of disease. And I will say, as of right now, we do not have a clear way how to prevent the progression of disease to something like myelofibrosis. So really the mainstay of treatment is management of the hematocrit, so aiming for a hematocrit of about 45%. And this can be done in a few different ways. In patients who are low risk, you can consider phlebotomy alone. For those that are high risk, you should think about adding a cytoreductive agent. The most common one we use here in the United States is hydroxyurea. And other options include the JAK inhibitor ruxolitinib, which is now approved in the United States for PV when the hematocrit is not controlled with phlebotomy and cytoreduction alone. And we also have a interferon formulation that can be used for the management of PV. So how are studies kind of informing our standard of care currently? One, I think, very important study that was published in the Journal of Clinical Oncology last year looked at ruxolitinib versus best available therapy in hydroxyurea treated polycythemia vera. So the primary endpoint was a complete response, which was seen in 43% of the ruxolitinib arm versus the best available therapy arm. And there were several very interesting secondary endpoints reported as well. Honestly, I think this is the most interesting and important part of this study, are some of the secondary endpoints. And really the interesting part was, for the first time, this study reported on depth of response correlating not just with improved hematocrit control, but improved event-free survival. So when you look at some of the primary endpoints like duration of complete remission, significantly better in the ruxolitinib arm, event-free survival, significantly better in the ruxolitinib arm, but then they looked at all patients who achieved a molecular response as measured by JAK2 variant allele frequency. And what was quite remarkable was in the patients who had some sort of molecular response, whether it be partial or complete, they had significantly better event-free survival, meaning no thrombosis, hemorrhage, progression to myelofibrosis or AML, or death, compared to those that did not achieve a molecular response. So the reason this is so important is, as we think about molecular responses in chronic phase MPNs, these may ultimately serve as a way of identifying therapeutic strategies that have disease-modifying potential and potentially can delay or halt progression of disease. Another very exciting drug that is in development for polycythemia vera is rusfertide, a hepcidin mimetic. So the phase 2 REVIVE study was published earlier this year in the New England Journal of Medicine, and rusfertide was utilized for patients with phlebotomy-dependent polycythemia vera, with the primary endpoint being liberation from phlebotomy for a 12-week period with an adequately controlled hematocrit. So this is actually a very nicely designed and very interestingly designed study. So essentially, all patients that were on study were initially initiated on treatment, and then they underwent a time where they were blinded and taken off the drug. And in those patients, very predictably, their necessity for phlebotomy returned. So it was quite remarkable. And as you can see, if you look at the patients that were kind of in the primary endpoint analysis, the patients that were on rusfertide, 60% of them maintained their response to being phlebotomy free. And the patients that went to placebo and were taken off rusfertide, only about 17% of patients actually maintained a phlebotomy-free period. So very interesting drug, works quite effectively at reducing the need for phlebotomy. It's yet to be seen whether there's the same sort of disease-modifying potential that, say, something like ruxolitinib or interferon has, but nonetheless, a novel drug that hopefully we'll be able to add to our toolkit for PV. I do want to highlight the side effects that can be seen with rusfertide, and I think the most important one to mention is that 5 patients on study developed a early stage skin cancer that ultimately could be resected and not require any additional treatment. The investigators ultimately deemed these to be unrelated to the study drug, but it's still a signal that needs to be looked at long term and will need further monitoring moving forward. Next, let's move to ET, or essential thrombocythemia. So, much like PD, the goals are reduce burden of thrombosis and hemorrhage, manage symptoms, and prevent or delay inflammation. One of the pearls to remember is patients with ET can paradoxically have increased risk of bleed along with clotting, because as we have a greater and greater thrombocytosis, there's a risk of development of acquired von Willebrand syndrome. So for those patients, we typically would not use aspirin until their platelet count is under control. Now for our high-risk patients, which is typically defined by using what's called the IPSET score, we do recommend cytoreduction, and cytoreduction can be done with either hydroxyurea or macrolide. One of the novel therapeutics that's in development in ET is bomedemstat, which is an LSD1 inhibitor. And this was a abstract at ASH 2 years ago, looking at several patients, about 60 patients, who were previously treated with hydroxyurea that received bomedemstat. And in patients who are eligible for response, about 36 patients, there was a remarkably high rate of platelet control, 94%. 67% also had variant allele frequency reduction of one of their driver mutations. The most common side effect was alterations in taste, which was seen in about 43% of patients, and about 25% of patients with constipation. Thrombocytopenia was also seen, which is an on-target effect of the drug, and the drug dosing does need to be titrated for those patients that develop thrombocytopenia. This promising phase 2 data has led to the development of a phase 3 study, which has been planned and will be enrolling to ultimately, hopefully, investigate whether bomedemstat should become a standard agent for the management of ET, particularly in those that have uncontrolled disease with hydroxyurea. Now, I do want to spend some time talking about interferon therapy in MPNs. So interferon therapy has been broadly used in chronic phase MPNs, most commonly in either polycythemia vera or essential thrombocythemia. Some of the benefits is there is a robust body of evidence to show us that molecular remissions can be achieved with interferon. Some patients are actually able to discontinue interferon and undergo a time period of a treatment-free remission, and the newer formulations may be better tolerated. Now the drawbacks is it is an injection or IV route of administration. The side effects can be flu-like symptoms, nausea, fatigue, muscle aches. There can be depression, so you do need to exercise caution with use of interferon in those that have other illnesses such as depression, anxiety, bipolar disorder, or other psychiatric diagnoses. And in patients with advanced myelofibrosis, interferon does not really have much of an impact on their disease. So what body of evidence do we have for interferon specifically? So the first abstract I'd like to highlight is the phase 3 DALIA trial. And this looked at all chronic phase MPNs that had an indication for cytoreduction of some sort. So patients were randomized, and ultimately the primary endpoint was a molecular response in their JAK2 variant allele frequency at 18, 36, and 60 months. Interestingly, there was no significant difference between hydroxyurea and PEG interferon. For the patients that did achieve a response, the response seemed to be more pronounced in those that were treated with PEG interferon. And then when you look at complete hematologic response, similar rates between PEG interferon and HU. So in my mind, the way I interpret this is hydroxyurea is not a medicine that is completely gone in the era of interferon. I think you need to be thoughtful and careful about who would benefit best from interferon versus who would benefit best from hydroxyurea. Now, we do have more and more data in PV specifically, polycythemia vera, that is supporting the use of using interferon early on. So this is the PROUD PV study, and this looked at time spent in complete hematologic response in the two study groups. So you have your intervention arm, the ropeg arm, versus the control arm, the hydroxyurea arm, with a significantly higher time spent in remission for those patients that were on the ropeg arm. They also looked at event-free survival, much like what was seen in the MAGIC PB study with ruxolitinib, and again, significantly improved event-free survival in those patients that were treated with interferon. There's also a study that looked specifically at low-risk PB that looked at ropeg interferon versus phlebotomy alone, and better hematocrit control in those that received ropeg. No patients had disease progression, lower rates of phlebotomy, and patients had improved the one thing to kind of remember is when looking at symptoms, though, symptom burden still was somewhat higher in those that ultimately were treated with interferon. So there is somewhat of a trade-off there looking at disease control versus symptom burden. The other very interesting thing is, should we be thinking about increasing use of interferon for our young patients, our adolescent young adult patients, 18 to 39-year-old patients, specifically because interferon may reduce the risk of progression to secondary myelofibrosis. So, as I mentioned earlier, I think there still needs to be a lot of thought about which cytoreductive agent is best for which patient. In my mind, in young patients with PV or ET that have an indication for cytoreduction, interferon should be strongly considered. Next, let's move into myelofibrosis. So, over the last 15 years or so, we have had significant evolution in the tools to risk stratify myelofibrosis. We've gone from our clinical scores, like IPS and DIPS, to the DIPS Plus, which incorporates cytogenetic data, to now what I call the molecular era prognostic scores, where we have scores such as the MIPS version 2, the GIPS, and the MySec-PM that all incorporate whether or not molecular mutations are present in someone with myelofibrosis. High-risk mutations specifically are ASXL1, EZH2, SRSF2, IDH1, IDH2, and U2AF1. So what is our approach to the management of myelofibrosis at the University of Chicago? Really, when thinking about myelofibrosis, the big question you have to ask yourself is, when should a patient be at least considered for transplant? So typically, for those patients who are transplant eligible that have an intermediate or high risk clinical risk score, we will at least refer for evaluation. For those patients that have high risk mutations but otherwise low risk disease, we will consider referring those patients for transplant evaluation. And then the mainstay of treatment are the JAK inhibitors. In this day and age in the United States, we have 4 approved JAK inhibitors. We have ruxolitinib, which has the longest approval and strongest body of data behind it. We have fedratinib, we have pacritinib, which is preferentially used for those patients with thrombocytopenia, and momelotinib, which is preferentially used for those patients with anemia. So, one big thing to remember is when thinking about JAK inhibitors, symptomatic control, spleen response, but ultimately we don't think of JAK inhibitors as being something that significantly modify the progression that you see in patients with myelofibrosis. I really like this algorithm. It can seem quite complicated, but in my mind, the 4 boxes that I've highlighted kind of show when I think about using the specific JAK inhibitors that we have available to us. So ruxolitinib tends to be my preferred JAK inhibitor for those with preserved blood counts. When patients have significant anemia initially, or with or without splenomegaly, I think about momelotinib. For patients with severe thrombocytopenia, I think about pacritinib. And fedratinib I usually use as a second-line therapy for patients that don't have an adequate response to ruxolitinib. And there is data, the FREEDOM study was just published a couple weeks ago here in Lancet Hematology to support the use of fedratinib in that space. Fedratinib has about a 30 to 40% spleen response rate in patients who were previously treated with ruxolitinib. There are several targeted therapies that are in development for myelofibrosis, particularly in combination with JAK inhibitors or as single agent. 3 that I would like to highlight are navitoclax, which works on the BCL2, BCL-XL pathway, pelabresib, which is a BET inhibitor, and then imetelstat, which is a telomerase inhibitor. So the Transform-1 phase 3 study looked at ruxolitinib alone with a combination of ruxolitinib plus navitoclax in patients with high-risk myelofibrosis and splenomegaly with a symptom burden. So the primary endpoint was spleen response, with a major secondary endpoint being symptom score. So the primary endpoint was met in this study. 63% of patients achieved the spleen response with Rux plus navitoclax versus only 32% Ruxolitinib alone. There was a toxicity profile with Rux plus NAV, the main one being blood count toxicity, so thrombocytopenia and neutropenia. And very importantly, there was no significant difference in symptom burden with Rux plus navitoclax versus Rux alone. So saying, while patients had increased spleen response rates, that did not correlate to improved symptoms. The patients did not necessarily feel better on this combination therapy, even if they had better spleen response. The other phase 3 study to highlight is the Manifest study, which looked at the use of pelabresib in combination with ruxolitinib versus ruxolitinib alone. The study design is very similar to the Transform study. Again, the primary endpoint was spleen volume response at 24 weeks, and a key secondary endpoint was symptom score reduction. And again, high rates of spleen response with the combination arm, 66% spleen response with pelabresib plus Rux versus 35% with ruxolitinib alone. However, much like what was seen with the Transform study, no significant difference in a 50% reduction in symptom score, or TSS 50 across the arms. The other thing to consider is the major toxicity seen was anemia and thrombocytopenia, although the grade 3 toxicities for either of those were not very significant in the pelabresib plus ruxolitinib treatment arm. The last novel drug I want to highlight for myelofibrosis is imetelstat, which is a telomerase inhibitor. So this is a phase 2 study that looked at relapsed refractory myelofibrosis. And what was found was after optimizing the dose of imetelstat at 9.4 milligrams per kilogram, there seemed to be fairly robust overall survival, so about 30-month overall survival. Typically when patients have progression with relapsed refractory myelofibrosis, their survival can oftentimes be a year or less. So very promising survival data and very promising spleen data. So when you look at any patients who had a spleen response, about 10%, using the 9.4 dose, the optimized dose, about 37% of the patients had that. Of note, the gold standard for spleen response is 35% reduction, and only about 10% of patients had that. When you look at symptom response, about 32% of patients had a 50% response of their spleen or their symptom burden or more. This is informing a phase 3 study in relapsed refractory myelofibrosis, and that study is actually going to look at overall survival as its primary endpoint. So one of the few studies in myelofibrosis we have where overall survival is specifically going to be the primary endpoint, as opposed to spleen response or symptom response. There are adverse effects that you need to watch out for with imetelstat, the major ones being hematologic toxicity, and then other things that can be seen are nausea, diarrhea, fatigue. So I think one of the big questions we have as a field for myelofibrosis is what does it mean to have disease modification? So historically, as I mentioned, JAK inhibitors do not seem to modify the natural history of disease. The goal being, do we have therapies that can reverse fibrosis, improve blood counts, and delay the risk of progression to, say, accelerated phase or blast phase? We also need to figure out what are the best surrogates for measuring disease modification. Is it molecular response, cytokine modification, fibrosis, improvement in blood count? I would say as a field, we still don't quite know how to fully define disease modification, and therefore it makes it difficult to incorporate it into all of our clinical trials. Now I'd like to move on to the management of accelerated and blast phase disease. So as mentioned earlier, this is defined by a blast count of 10 to 19% in the accelerated phase and greater than or equal to 20% in the blast phase of disease. So what are the risk factors for transformation? There are several that have been well identified. So we know that patients who have myelofibrosis are at higher risk of progression to blast phase. Cytoreductive agents such as phosphorus, chlorambucil, hypobrumin, and busulfan are associated with progression to blast phase, although we very infrequently use those in this day and age. Lab parameters such as circulating blasts, cytopenias, and leukocytosis are associated with progression. And then the myelofibrosis scoring system, high-risk patients not only have reduced overall survival, they have higher risk of progression to blast phase. When looking at blast phase progression by disease type, so over a 20-year period, about 4% of patients with ET will progress, 7% of patients with PV, and about 14% of patients with primary myelofibrosis. So, MPNs in the accelerated blast phase are not the same disease molecularly as AML. I think it's very important to note this. So in AML, we see lots of 3 mutations, NPM1 mutations. On the other hand, in accelerating blast phase MPNs, we see enrichment for IDH1, RUNX1, ASXL1, and TP53. So we have to keep that in mind when thinking about how to treat accelerating blast phase MPNs. They are not the same disease molecularly as AML. Historically, when patients have progression to blast phase, survival is dismal. So even in kind of a somewhat modern cohort, 2010 and beyond, the 3-year survival reported by the Mayo Group was about 10%. One thing that's happened in the AML landscape is that there have been several novel therapies that have been developed and approved for use. So you have your targeted therapies, such as the FLT3 and IDH inhibitors, and then you have venetoclax, the BCL2 inhibitor, that's become our new standard of care in combination with low-intensity chemotherapy for older adults with AML. So one question that we asked at the University of Chicago as part of a multi-center analysis is, have all of these new AML drugs improved our survival for accelerated blast phase MPNs? And the short answer is no. The median overall survival is still less than a year. And when we looked at survival based on different strategies, so whether it was intensive chemotherapy, DNA methyltransferase inhibitor plus venetoclax, or other DNA methyltransferase inhibitor-based strategies, median overall survival was not significantly different across those groups. So much work still needs to be done to move things forward for accelerated and blast phase disease. So how do we improve outcomes there? In my mind, there are 3 things. We think about identifying patients at highest risk of progression and intervening early. That could be with medication, or that it could be potentially with transplant. And then we need to think about how do targeted therapies work in accelerated or blast phase disease. So one potential targeted therapy route is IDH inhibition. About 25% of patients with accelerated or blast phase disease will have a mutation in IDH1 or IDH2. So we did a retrospective study now 4 years ago that looked at IDH mutated patients that received an IDH inhibitor, and we found very promising results. So 4 of our 8 patients were on therapy for a year or longer. And our longest responding patient was on therapy, an IDH inhibitor, for about 4 years before there was progression of disease. Other groups have shown similar data. So this was studied by the MD Anderson group that looked at the use of IDH inhibitors in this population, where they also found fairly promising CR rates and survival data. And a multi-center analysis done by the Mayo Group showed that both HMA venetoclax and IDH inhibitor therapies seem to be a fairly reasonable treatment approach for IDH mutated in blast phase. Other strategies that are in development are thinking about combining JAK2 inhibitors with IDH inhibitors. So this is preclinical data from mouse models that shows the combination of this therapeutic approach not only addresses the blast phase component of disease, but also the chronic phase MPN component of disease. And this served as the basis of a study that's ongoing that looks at the IDH2 inhibitor enasidenib combined with ruxolitinib. And small numbers, only about 6 patients that are enrolled, but for the accelerated and blast phase patients, 2 out of 5 had a complete response, which is quite promising. So how do we think about treating accelerated blast-based disease in the current day? We do think that assessment for IDH1, IDH2, and TP53 mutations is essential. For patients who are in the accelerated phase, they could potentially go directly to allo transplant without receiving additional therapy to help reduce their blast burden. For our blast-based patients, we do typically recommend initiation of treatment, whether it be an IDH inhibitor or a hypomethylating agent-based therapy, with ultimately the goal being trying to get to an allo transplant if the patient is an appropriate candidate for that. Other treatment strategies on the horizon for accelerating blast-based disease are boxed down below. So there's data to support BET inhibition, LSD1 inhibition, and a few other pathways such as V1, CDK9, DESP6, and hypoxia-inducing factor. So in summary, when thinking about how we treat PV and ET, our treatment is centered around reducing thrombotic risk with the appropriate cytoreductive agent. For myelofibrosis, considerations for JAK inhibition in patients who are symptomatic with splenomegaly, and then referring to high-risk transplant-eligible patients for transplant evaluation. And with accelerated blast-based disease, even with several new drugs that have been approved for acute myeloid leukemia, they don't seem to have the same sort of impact in the accelerated or blast-based space. So with that, I want to thank everyone for their attention, and again, for the very kind invitation for me to speak. I'm happy to take questions, and this is my email address, and I'm also active on Twitter. If anyone wants to reach out to me, I would like to avenues. So with that, thanks so much, everyone, for your time.
Thank you, Dr. Anand Patel, for a very crisp, short, and fantastic lecture. Very crisp and crystal clear. I think all the points were very, very crystal clear. And I now request all our discussants to please put the raising sign so that we can start our question and answer session with Dr. Anand Patel.
So one of the questions is management of pre-fibrotic MF with moderate splenomegaly. So that's, in general, if patients have splenomegaly and it's symptomatic, I tend to favor using a JAK inhibitor to help reduce the spleen size. So two reasons. One is, spleen reduction will certainly help with transplant candidacy if the patient has progression down the road. The other is, while JAK inhibitors are not thought to be disease modifying, if you look at long-term follow-up of patients treated on the COMFORT studies that established the role of ruxolitinib, there did seem to be a survival benefit that was seen for those patients that received ruxolitinib versus the placebo. So I would still think about JAK inhibition. I typically don't use JAK inhibition combined with cytoreductive agents such as hydroxyurea. I haven't found that my patients have been able to tolerate that combination very well. And typically the JAK inhibitor will offer some reduction in blood counts also.
Thank you. Any discussing want to ask any question? So yes, another question is from Dr. Meenakshi Suri. How long can ruxolitinib be advised in primary myelofibrosis?
Yeah, so I mean, ruxolitinib is considered to be an indefinite therapy, so as long as patients are tolerating it, as long as they're having disease control, it can be continued. I will say we do have data to show that for patients who are enrolled on the ruxolitinib myelofibrosis studies, at the 5-year mark, 75% of them have stopped ruxolitinib for one reason or another. So that could be intolerance, that could be worsening anemia, that could be disease progression, or that could be transformation to the blast phase. So, when I counsel patients, I do ultimately think about, ruxolitinib is a therapy that you're on for an extended period of time, but there's a very good chance you will need to stop it at some point because either your disease will progress on ruxolitinib or there will be side effects, the most common one being anemia or worsening thrombocytopenia that may limit our ability to use ruxolitinib moving forward.
Thank you. Another question from Dr. Ambedkar. A young patient, primary myelofibrosis, uses splenomegaly. Can you take the patient for BNP at once?
Yeah, so we now have some consensus guidelines about splenomegaly in myelofibrosis and considerations for transplant. And we, in general, and again, this is consensus based, but it does seem that if the spleen is larger than 27 meters or so in its largest diameter on imaging, those patients are at very high risk for poor outcomes post-transplant, mainly due to failure of engraftment. There are data to show, and again, these are all kind of small retrospective studies, but there are data to show that patients can safely receive irradiation of the spleen if needed before transplant to reduce spleen size, or a splenectomy can also be considered. For patients who have not been on a JAK inhibitor, I would strongly recommend trying a JAK inhibitor and seeing if that will allow for some spleen control. But if not, and ultimately spleen size is the main barrier to allo transplant, you should think about other strategies, whether it's radiation or surgery, as long as you have expertise within your center to do either of those things, whether it's a radiation oncologist that has experience of doing that sort of radiation, or if there's a surgeon that has that expertise to do splenectomies in patients that oftentimes will have low blood count and thrombocytopenia.
Thank you. Dr. Anand, Patel, we have no access to pediatric, we don't have any access to mobility in our country. And many of our patients do come to us with a platelet count of less than 50,000. And it's very difficult for us even to start with non-transplant because that is what is available in our country.
Yeah.
So, any dose reduction if we can use for less than 50,000 also, and at what lower level of dose can we go with less than 50,000 non-transplant?
Yeah, so that's a very good question. So what's been shown is if patients are receiving less than 10 milligrams BID of ruxolitinib, it is probably not a therapeutic dose. So, sometimes I think they're getting 5 milligrams of ruxolitinib once a day or twice a day, and while they're on the medicine and their blood counts are tolerating, they probably are not deriving much benefit from it. So I would say, maybe you could start at 5 milligrams twice a day and make sure that their blood counts are not dropping on that dose, and then slowly try to get them up to the 10 milligrams twice a day dose. And ultimately, their platelet count will require close monitoring. You will need to be cognizant of, if their platelets are persistently in the 10 to 20 range, that makes me very worried.
Probably have to consider transfusing them.
How are you?
That's when they're at risk of needing complications. For the anemia part, so there have been strategies that are explored to get ruxolitinib plus ESA, ruxolitinib plus danazol. In the United States, we have studies that get ruxolitinib plus luspatercept. So for anemia, you can think about add-on strategies that should be better tolerated, whether it be danazol, ESA, or something else.
quickly and get them to transplant. For my transplant ineligible patients, I typically still use hypomethylating agent alone.
It's very, very clear. Thank you. So any discussion what those? Yes, one more question has come up from Dr. E. Monten. What is your upper limit of platelet for which is contraindicated for antiplatelets in MPN?
Yeah, so that's a very good question. I think it depends on what sort of testing you have available to you. So if you're able to do von Willebrand panel and ristocetin testing, then you can check and see if they have acquired von Willebrand. And if they don't, then you can start an antiplatelet drug. If that test is not available, in my mind, a good rule of thumb is if the platelet count is over 1 million and you don't know for sure if they have acquired von Willebrand or not, it's probably worth avoiding the antiplatelet drug until you get their platelets down below 1 million.
Thank you. So any other discussion want to ask? Any other question? Well, so I think there are no raising signs and no more questions in the chat box. Well, thank you so much, Dr. Anand Patel, for a fantastic lecture, lovely lecture, and very crisp and very clear lecture.
Thank you. No, it was my pleasure. Thank you so much for inviting me. The questions are all excellent. These are the questions that I know what weigh on our minds in clinic every day. These are the very hard decisions to make. So these questions are all great.
Thank you. Thanks a lot for accepting our invitation as our guest speaker for the day. Thanks a lot.
Yes. Take care, everyone.
And I also thank all our discussants as well as audience to participate in this webinar. Meet you tomorrow at sharp 11:30 a.m. Goodbye for now. Thank you.
પ્રિન્ટ મશીન ચાલે તેનો અવાજ આવે ને અહીંયા મેં સ્પીકર ચાલુ કરેલું ને એ જ અવાજ આગળ પેલામાં જાય વેબસાઇટ પર. જો મેં સ્પીકર બંધ કરી નાખ્યું તો આગળ અવાજ જવાનું બંધ થઈ ગયો. તો હવે શું
આઉટપુટ જાય છે કે નથી જતું?
આઉટપુટ છે ને કેવી રીતે જાય છે, આપણે જે સ્પીકર ચાલુ કરીએ ને અહીંયા તેનું આઉટપુટ જાય છે. ડાયરેક્ટ જવું જોઈએ ને તે નહીં જતું.
અચ્છા, એટલે માઇકમાંથી કેપ્ચર થઈને જાય છે ને?
હા, જો તમને એક
કાલે એનો કન્ટિન્યુ કરજે, પછી હું જોઉં ચેક કરજો.
1 મિનિટ ટાઈમ છે તમારી પાસે કે બીઝી છો?
ટાઈમ તો છે.
જો તો દેખાય છે.
વિડીયો કોલ જ કરજો.
હવે આ જે ચાલુ થઈ ગયું છે ને કાં તો આ ગાયબ થઈ જવું જોઈએ. એ નહીં થતું. એવું લખેલું છે. કયો સાઉન્ડ આવતો? આપણા અહીંયાના સ્પીકરમાં સંભળાય જ્યારે આપણે ચાલુ કરીએ ને. હા, હેડફોનમાં સંભળાય. હા, હવે અત્યારે જે ચાલુ છે ને એકવાર મ્યુઝિક એ નહીં સંભળાતું અત્યારે મને. કેમ કે ડેસ્કટોપ ઓડિયો નહીં. અગર જો હું વેબસાઇટ ચાલુ કરીને જોઉં ને તો વેબસાઇટમાંથી અવાજ આવે મને. આયરા? હા. હા, કનેક્ટ છે. ફોટો પાડી શકું? એક મિનિટ. ફોટો મોકલી લો મેં તમને. ઓડિયો મોનિટર. ડેસ્કટોપ વાળા કે મોનિટર ઓનલી? મોનિટર એને આપો. ડાયરેક્ટ ચાલુ. જેમ તમે ગયા આવ્યા. કયું? હેલો હેલો હેલો. ના, નહીં આવતો. હેલો હેલો. હા, ઝૂમ ચાલુ જ રાખલું છે મેં. માઇક
અચ્છા તો એકવાર ટેસ્ટિંગ સ્ટ્રીમિંગ ચાલુ કર તો ટેસ્ટ
સ્ટ્રીમિંગ ચાલુ જ છે.
ચાલુ જ છે સ્ટ્રીમિંગ.
હા, તમે કોઈ બીજા કોઈ એમાં જોઈ લો ડિવાઇસમાં.
પણ તું ત્યાં જ ખોલ ને પણ કોક એમાં લેપટોપમાં ખોલી લે.
લેપટોપમાં ખોલી લો. ચાલો 1 મિનિટ.
હા લેપટોપમાં ખોલી લે.
બાજુવાળાને કે બી આવ્યો કે તું તારું ચાલુ કરી દેજો મશીન.
હા
કેમ ચાલુ નહીં થયું? હમ બહારથી અવાજ આવે છે.
એવું તો શું તકલીફ હોઈ શકે. એવું તો શું તકલીફ હોઈ શકે.